Hello, everyone. I have the pleasure to welcome all of you to this surgery online. Today we have a great guest, an expert. We'll present him to you in a minute. My name is Peter Grasso. I'm head of clinical support for the portfolio of the Vibrant Sound Bridge, Bone Bridge, and Adhere. And let's start with the first slide, please. Okay, next one. Here we are. So before we dive into the topic of today, I would like to ask you to follow some tricks and some tips for the participants. Please name yourself, your organization, your country. You can do that by clicking on the participant panel, click on more, and then rename yourself. Very important, in order to avoid any background noise, just mute the microphone and use it only, activate it only if you would like to speak. In order to have a stable internet connection so that everything is working fine, it's a nice flow, please close all other programs and leave only Zoom. And yes, of course, this is a very interactive meeting. So please write comments in the chat, but you can also then ask questions. And I really recommend to do that, to take some notes if you have some questions during the session, this event. And then at the very end, we will have the possibility to discuss them. Very good. So as of tradition, of the surgery online event, today we have an expert, we have a very special guest. And I'm very happy to introduce to you Professor Miklós Tóth. He has 20 years of experience in the field of the anatomy of the temporal bone. But even more, 30 years of experience, of clinical practice experience, research in the field of hearing. And of course, you can ask him lots of questions about morphology, physiology, but also CT scan and MRI of the temporal bone. He has been a lecturer at many international postgraduate training events, as well as author of a book, and I have it here. And we will hear more about it later. I hope you can see it. It's called the same name as our surgery event, surgery online event, Anatomical Guidelines for Temporal Bone Surgery. So without further ado, I would like to present Mr. Dr. Miklós Tóth to you. Dr. Tóth, are you there? Hi.
I am
Can
here.
You hear us? Hi. Thank you for joining, and thank you for sharing your knowledge. Please, I know you have some slides. If you would like to show us some information about the anatomy of the temporal bone, please.
Hello, everybody. My name is Miklós Tóth, as you heard that. And in the following 40-45 minutes, I would like to say something about the anatomy of the temporal bone. This topic is really huge. And this 40-45 minutes not enough to speak about all the things within the temporal bone, but I selected a few important parts, and I would like to start selected pictures. So, okay. You can see two temporal bones, right side. Left, you can find a temporal bone from adult, and on the opposite side, a newborn. It is very important to see not just the morphology in adults, but in newborn or the children. The anatomy is not a phone book. This is as a video. I say it because if you want to understand the different, not typical clinical situation in the OP theater, or just keeping a lecture for students or colleagues, it is understandable if you can see what happened within the temporal bone. That is why, to understand the embryology, not all the things, but the most important thing within the temporal bone helps a lot of. So this is a right temporal bone from adult. And what is the difference between newborn and adult? The tympanic cavity here and here, the depth of the ear canal is the same. A newborn and adult the same. But where can we find a huge change after birth in the tympanic bone? About 10 times so larger bony mass can we find here in the adult ear canal as in a C-shaped tympanic ring. This is the bony osseous canal in newborn. So here we can find a lot of changes. The other part is the mastoid process. In newborn, we can find just the antrum, and the mastoid process is hardly visible. In a newborn, in a well-pneumotized temporal bone, we can find normally a huge mastoid cavity. And in the screma, this is a bony plate. In an adult, this is larger, and the zygomatic root here. This is just a small road. It is really a large bony mass. If we would like to understand this area, so to have more details, we can see in cross-section the same situation. Right temporal bone, horizontal cut in a newborn, and in adult in the level of the lateral semicircular canal, lateral to the inner ear, cochlea and vestibule. Lateral to the inner ear, we can find the tympanic cavity in newborn and in adult. Here is the cochlea, internal auditory canal, and the vestibule. This area is the same, and it is important, for instance, for implantation of a vibrant sound bridge. The most common implantation area for vibrant sound bridge is the short process of the incus. If you make a mastoidectomy, you can find the short process here and the incuda fossa, and it means in newborn you could make that without any problem. If you see this drawing, you can find the newborn and the adult temporal bone. The center, the inner ear is the same, the tympanic cavity as well. In 3 directions can be find growing after birth. So dorsomedially and laterally, this is the mastoid area, the zygomatic root, and the petrox apex. One of the most classical approach within the temporal bone, this is the mastoidectomy. Nowadays, the mastoidectomy is not so often used, but used to be maybe 50s, 60s. For instance, in Los Angeles, that was an everyday action. In the Hauser Institute, the surgeons made 4 times, 5 times mastoidectomy, because one of the most important therapy was for chronic or acute mastoiditis or middle ear infection, just a mastoidectomy. But what does mean mastoidectomy? This is not just a hole in the mastoid process. If you would like to make a good mastoidectomy, you should learn the skeletonization. Skeletonization of the middle cranial fossa. It means just to leave a very thin bony shell around the temporal lobes, so the brain itself. You can find here just a bony plate without any air-filled remnants. The other important structure is the sigmoid sinus. So if you drill, you should follow the expected pathway of the sigmoid sinus. At the end, you have got a bony shell along this sinus and skeletonization of the posterior and superior wall of the bony ear canal. The mastoid tip should be also open. This is the digastric ridge. And if you remove all the bony cells between these mentioned structures, you have to identify the labyrinth. It is not so easy. You can skeletonize the lateral, posterior, and anterior semicircular canal. And if it's necessary, here in this area, you can skeletonize the facial canal, mastoid portion as well. In many cases, in cases of exostosis of the ear canal, you should make a widening of the bony ear canal. This is a so-called canalplasty, in order to see from one microscopic view the whole tympanic membrane. So this is a typical large mastoidectomy. A special area of the tympanic cavity is the supralabyrinthine recess. Where can we find that? Here you can see three different variations of the supralabyrinthine recess. Superior lateral and posterior semicircular canal. Again, the superior lateral semicircular canal. Anterior to that, you can have a very shallow, a deeper, and a very deep area. This is the supralabyrinthine recess. What kind of borders can we find here? The tympanic portion of the facial canal here as well, the geniculate ganglion, and parallel to that, in that level, the labyrinthine portion of the facial nerve. So here, you have to be very careful during surgery. And this is the dura. If you have a focus here, focus of the infection, because as repeated infection, you have to clear that. It is a very sensitive area, but in special cases, we have to clean this area. So this is a supralabyrinthine recess. If you can open that, you make a good skeletonization of all the mentioned structures. You are really a good surgeon. So it is worth to try to do that. How can you skeletonize? I would like to explain a few things about the development and the normal structure of the Otic capsule. So this is a bony shell around the membranous labyrinth. This is a schematic drawing of the Otic capsule. Otic capsule had three layers: an inner layer, a middle, and an outer layer. If we speak about the blood supply of this bone, we can say the internal carotid artery is the supplying artery of the most inner layer. This is the endostyle bone. The outer layer is supplied by the external carotid artery from the tympanic cavity. And between both, we can find a avascular layer. So there is no blood vessel. This is so-called enchondral bone with intrachondrial bone. The normal feature of this avascular layer, then we can find cartilage islands. And sometimes we can find this cartilaginous islands in this layer in the CT scan as well. This is the cochlear cleft. If we look at this 4-year-old child histological slide from the promontory, this is a very thick Otic capsule, and this crack here, this is the cochlear cleft, and it is large enough to identify in the CT scan. This is the endostyle bone, this is the enchondral middle layer without any blood vessel, and this is the periostyle bone with many blood vessels. How develops that? The first ossification can be found outside, just below the mucous membrane of the tympanic cavity. On the inside after that, the endostyle bone, and between both layers, at a 20-week-old fetus, we can find just a hole. It contains bone marrow, and this bone marrow produces multipotent cells going in the first 3 months after birth to give the immunity of the middle ear. So this is a very important area, and later on it will be filled with compact bone. This is the enchondral bone. How can you use in the everyday activity this information? How can we make a good skeletonization? If you look at intraoperative picture, I made a subtotal petrosectomy. I removed the superior and posterior wall of a left temporal bone. This is the medial cranial fossa skeletonized sigmoid sinus. We can find here area. This is a lateral semicircular canal covered with bloody area. If we see a histological drawing in this area, this is the mucous membrane, periostyle bone, enchondral bone, and the endostyle bone. And this is the labyrinthine part of the membranous labyrinth. So without any touching drilling, we can see that if we remove this area filled with blood vessels, we are opened the avascular layer. We can see that this is yellowish. So if you see this area, yellowish area, without any blood vessel signs, you can say I am in the level of the endostyle bone, the enchondral bone. And this is the level that you should reach if you make a good skeletonization. So you should remove all the red parts of the labyrinth. If you drill more bone away, you have to reach this endostyle bone, and this is the classical blue line technique. The bone is so thin that it is transparent. So this is a good technique. How can you make a proper skeletonization? A little bit easier part, auditory ossicles. This is a beautiful sculpture. You can see from lateral, anterior, medial, and posterior, the incudomalleolar joint, incudostapedial joint. Is really beautiful how it is positioned and where can you find it. The largest part of the auditory ossicles can you find not behind the tympanic membrane, but above that, in the epitympanum. Only the long crus of the incus and handle of the malleus and the stapes can you find here. A few pictures about the ossicles. This is the isolated malleus. This is the histological slide from the same bone. You can find the close connection to the chorda tympani. This is the Prusak space. In many cases, this is not a hole. You can find here mesenheim or different mucous folds. And a very important thing, this cartilage cup here on the lateral wall of the lateral process, if you would like to remove during tympanoplasty the whole tympanic membrane from the malleus, it is worth to have this level between the cartilaginous cup and the bone itself, and it will be easy to dissect the tympanic membrane completely as far as the umbo from the whole handle of the malleus. The head of the malleus has also bone marrow. You can find here in the axial histological slides the incudomalleolar joint. This is a real joint with cartilage, hearing cartilage on both surfaces, and the capsule of the cartilage, the anterior mallear ligament. It looks so with bone marrow, and this is a special turning of the malleus as well towards the incus. It helps to keep both the incus and malleus together. The incus itself, again, the macerated bone from medial. This is the lenticular process. This is a convex surface for the concave surface of the head of the stapes. Here in the body, you can find as well bone marrow, again, histology, incudostapedial joint between the stapes and the incus. This is the long crus of the incus. And you can see two nerves, medial to that, the facial nerve in its own canal, and the chorda tympani, just medial to the tympanic membrane. And ossification of the incus is also very interesting. In the 16th embryological week, we can find just on the lateral side of the long crus of the incus, the first ossification center. In the following weeks happens the whole ossification, and this is the starting point of the incudostapedial joint. And in many cases, we can find atelectasia of the middle ear, and the first bony part which will be destroyed is the long crus of the incus. You can find here and here, sometimes in the body as well. Stapes. This is the third bone. The classical form of the stapes is here. This is the foot plate, very thin. The posterior curved and the anterior straight part, and this is the head of the stapes. if we look the foot plate, this is curved posteriorly, and anteriorly we can find a wedge form part. This is a sharp angle. It is very typical. If you can't see that, it is a sign that maybe you have got a problem with the development, so malformation of the stapes, and in this case the facial canal has also developmental failure. How can you use this anterior part in other way? If you make a line along the inferior border of the foot plate, follow that, here in this area you can find a fistula ante fenestra. This is cast preparation filled with colored material. This is the posterior and anterior cruise of the stapes, the foot plate, and this is remnant of the stapedial artery. In special cases, you can find intraoperatively stapedial artery. This is the round window niche, and this is a bony part between the oval window and round window. This is the subiculum. This is important in special cases. If you have a cholesteatoma, a huge mass here, sometimes it is a very well usable landmark, and the different parts of the stapes. For instance, this hole is because in this case, that was an existing remnant of the stapedial artery. Tympanic membrane. This is a well-known cone-shaped membrane. This is the pars tensa and pars flaccida, and we can find three layers. The outer layer towards the ear canal is epithelium. Epithelium, stratified epithelium. This is one layer epithelium. This is the tympanic cavity mucous membrane, and between that, in different layers, fibers, connective tissue fibers. This is an endoscopic view of a classical tympanic membrane, right side, handle of Malleus, pars flaccida, pars tensa, but this is not a healthy tympanic membrane. If the connective tissue becomes thinner, in case of atelectasia between both epitheliums, the tympanic membrane becomes transparent, and after that you can see very well all the structures, the auditory tube, the hypotympanum, round window, and oval window. In this case, you can say, okay, this is the beginning of the atelectasia without any retraction, but this is a case of a bad chronic malformation of the auditory tube. And this is how looks the tympanic membrane in case of ventilation problem. Auditory tube doesn't have a good function. And this is the tympanic membrane, slightly meningo-sclerotic and a little bit retracted. After Marsava maneuver, it bulges out. This is a stronger picture, and in special cases, you can find a finger-like bulging outwards, so toward the ear canal, if the tympanic membrane very thin is. So we can see here after and before Valsalva maneuver. In a very heavy dysfunction of the auditory tube, we can find such a temporal tympanic membranes. You can find meningo-sclerotic area in the pars tensa, but here, atrophic area, in case of acute infection, in this area can develop perforation. This is the same patient, right side and the left side. And the similar situation can be found in this case. This is a atelectasia grade 2. The long process of the incus is reached. This is the SADE classification. So this is atrophic area. On opposite side, you can find a malformation, a perforation, and very strong meningoschlerosis with a perforation on the other side in a grade 4 atelectasia. development of the tympanic cavity. If you would like to understand why happens retraction of the tympanic membrane in case of a malfunction of the auditory tube, it is worth to know how develops the mucous membrane after birth within the tympanic cavity. This is the right temporal bone, the different embryological unlungs, squama, petrous part, and the tympanic ring. The styloid process would be here. If we turn this right newborn from the medial side, we can find that. So this is from medial. This is the tensor tympani muscle with the tendon, the chorda tympani, malleus incus. This is the facial nerve, of course, cut it anterior and posteriorly just to show where is the position, and this is the chorda tympani. So we can find finger-like processes here anteriorly. This is the sulcus anticus, medius superior, and this is the posterior. So this bulges further and further, and between the chorda and the tensor tympani muscle, both the anterior and the medial will meet each other. And here in this area develops the tensor fold. Tensor fold is not other as two mucous membrane sacs will meet and form and duplicate. And here the superior and the medial between the short and long process of the incus here develops the incudal fold. Other pictures about this area. So we studied this drawing from Hamburg. That was a monography from 1905. 36 newborns and embryos was studied in this huge work, and I would suggest to read that amazing work. If we see the same situation here, the right temporal bone, the medial superior view, this is the head of malleus, this is the incus, stapes, the stapedial tendon. This is the foot plate of the stapes, and tensor tympani muscle and the tendon of the tensor tympani muscle, and this is the chorda. So we have got a huge surface between mesotympanum, so the space behind the tympanic membrane, and the space where you can find the largest part of the auditory ossicles. This is a large area, and the anterior one, almost the half of this area is covered with the tensor fold. Also a large area between both the short and long crus of the incus is covered with the incudal fold. This area, the isthmus, and this is very short. In case of a newborn, you can find these two areas covered. Later on, both will disappear, and the communication between the meso and epitympanum has a large surface. To see that, you can see here these drawings. The different compartment of the middle ear. This is the auditory tube, the osseous part. This is the protympanum, the mesotympanum, hypotympanum. Here is epitympanum, antrum, and mastoid. Wow. And this area, the epitympanum, antrum, and mastoid, is separated from this area, mesohypo and area and protympanum. And in case of the closed incudal fold and tensor fold, just the tympanic isthmus is the only way for the ventilation of the mastoid process. If it is there is a problem with the auditory tube function, this is the only way, and the Bernoulli law will result in a retraction in the posterior superior area of the tympanic membrane. That is why can you find in a lot of patients in grade 2 atelectasia, incus destruction. So this is a long story how develops it, but you can see To understand the atelectasia, you should know the embryology of the mucous folds within the tympanic cavity. Newborn from above, right side head of the malleus, body of the incus, and so many mucous membrane can you find in newborn. Fortunately, these disappears. Almost all the mucous membrane disappears, because if it would remain after birth as well, we should have a lot of patients with acute mastoiditis. That is the classical picture from Proctor, how it looks schematically. This is the reality. Tensorfold, right side, this is the open supralabyrinthine recess. If you remove all the cells, you can find a tensorfold. This is a vertical plane in almost all the cases. After removal of the tensorfold, you have got a free enter into the auditory tube. Histology. Just a few pictures. Why is it important to understand histology? If you see a histological slide, this is very confused. That is why I put to my book drawings, histological drawings, in order to give more information. How can you better understand the submacroscopic anatomy? So this is axial plane, facial nerve. This is a labyrinth with the vestibule, the cochlea. This is the auditory ossicles, the malleus and incus, the incus malleolar joint. This is the cog and non-vertical bony plate. If we go further, we can see the tangentially cut external auditory canal, the two ligaments of the posterior incudal ligament can be seen, the close relationship between chorda and the malleus, the tensor tympani muscle, how it looks, which is good with such a histological drawings. You can measure, because these are copies from original histological preparates. It takes time, a lot of time, really time-consuming work to have such drawings. But after that, with selected coloring, you can understand. Green means air-filled area of the tympanic cavity, and blue mucous membrane. You can see how thick the mucous membrane is. You can find here the tensor tympani muscle tendon. It is worth to know the tensor tympani muscle has a touching area not in the middle of the handle of the malleus, but anteriorly. That is why it has two functions, the muscle. Pulls the malleus medially, but make a turning as well. It is absolutely important because it can save the medialization of the stapes. And other section, you can find a tangential cross section of the pyramidal eminence, stapedial muscle, tendon of the muscle, and how can it reach the stapes as well, and incudostapedial joint as well. In the vertical section, this is also important to understand the different structures. Here can you find the lateral and posterior semicircular canals, and the angle between both structures. You can find the pathway of the facial nerve. This is the mastoid, and this is the pyramidal portion, and the chorda tympani exits the facial nerve in this area, and different levels can it happen, and goes further anteriorly. The stapedial muscle can you find always medial to that, and sometimes air-filled area medial to the stapedial muscle can you find. This is a deep tympanic sinus. Unfortunately, cholesteatoma can grow into this area, and to open this area posteriorly is almost never possible. So we have to come from anteriorly through the ear canal, or we have to make a canal bowl down technique to make the cholesteatoma removal more easy. This is again in the coronal section, the posterior incudal ligament. This is important for stabilization of the incus. If we would have just one ligament, the incus should not remain very stable. So you can remove the lateral part without any instability of the incus. If you make a modified boundy operation, we remove this part and stabilization of the incus will happen through this ligament. This is the facial nerve, facial canal. In the facial canal between bone and nerve, we can find a lot of veins and artery as well. And this is the classical picture, facial canal, stapes, around window niche, and this is the incus incudestapedial joint. And the mucous membrane, within that we can find the chorda, and this is a pouch. Sometimes we can find here this trulch space, and here we can find chronic infection. If you make a very proper operation, you can open this area in order to remove minimal invasive technique, the pathology, and the very thin tympanic membrane. And the protympanum is well. This is the tensor fold between the chorda and the tensor tympani muscle, and the tympanic nerve running on the surface of the promontory. This is the different terms of the cochlea. So I would like to show some pictures. How can we understand the histology, histological slides? It gives a lot of information because such a histology gives the same magnification what you need during surgery or in the praxis to make a good proper diagnosis. Facial canal. This is one of the most important and most interesting structure within the temporal bone. Right temporal bone. The labyrinth is filled with green dentist material. This is a silicone gum. Anterior, lateral, and posterior semicircular canals. The facial canal can be found, as I mentioned, in the angle between the posterior and lateral semicircular canal. It is always a good technique. How can you find during mastoidectomy, or how can you make a good posterior tympanotomy and the whole mastoid portion of the facial canal? So we have a vertical, a horizontal, and a medial portion, labyrinthine portion, tympanic, and vertical mastoidal portion. This area, this is the second genu, or we can say pyramidal portion, and this is the first genu here. The labyrinthine portion of the facial canal is short, about 3 to 5 millimeters long, and it is always curved because it is positioned around the first term of the cochlea. It is worth to know if you make a middle fossa approach or you make a facial nerve decompression, this is the supralabyrinth area. If you work with this supralabyrinthine area, you have to know this curved pathway. You will come here, and it is not so easy to see the whole curve, but with the drill, you can drill along the expected pathway. And this is the chorda tympani. Again, the development. It is again very important. The yellow color shows the nerve itself, and the brown color is the developing bone growing around the nerve. We can see normally a superior and inferior plate, both grows together, and will leave here a hole. Later on, this hole will be smaller. And if we look this macerated temporal bone, right side, lateral superior view. This is the promontory oval window. This is the round window niche cochleariform process. Now you can see where we are. This is the open facial canal. And you can see just above the oval window where we can find the stapes, a hole. This is a dehiscence. So if we have a patient with otosclerosis in this area, focal otosclerosis, we remove the crura and we will prepare here with a hook through this hole, which you can't see because this is outside the view of the surgeon. With a turning the hook cranially, you can damage through this dehiscence the facial nerve. Be careful. 20–25% of the cases you can find such a hole, not visible. This is the vertical vertical histological slice of the developing facial canal, facial nerve, a large vein, superior and inferior plate, and in this area can develop a dehiscence in case of remain development of the inferior plate of the facial canal. It looks so, or a complete dehiscence of the facial canal here. Cochlea. Right side, the tympanic ring is removed. This is a new bone. This is the promontory, oval window, round window niche, and behind the promontory we can find the 3 turns of the cochlea. If we remove the periostal and enchondral bones and we leave just the endostal bone, we can find a beautiful picture of the cochlea, first, second, and third turn. This is the geniculate ganglion here. In this area, the labyrinthine portion of the facial canal, and here was the tympanic portion, anterior and lateral semicircular canal, and other variations of the cochlea. Please note the axis of the modiolus. This is about horizontally. This is a little bit downwards turned. If we open the cochlea, what happens? We remove the promontorium, oval window, round window niche. This is the right side, lateral view, jugular bulb, carotid canal, and this is the curved pathway of the basal turn, or first turn of the cochlea. From the vestibule, we can find the scala vestibuli. From the round window niche, the scala tympani, and the spiral bony lamina. Just below the cochlariform process and the semicanal, we can find the second turn. If we look from other view, we can see the same. And relatively inferior view shows that we can, in special cases, we can open the third turn as well. And how looks a cochlear implant within the cochlea? A lateral electrode, it means if you put the electrode through the round window in the middle of the basal turn, it comes over the carotid artery and here touches the lateral wall of the cochlea, and the following pathway from this point of the electrode comes on the lateral side, on the outer surface of the cochlea. This is a flex 28, and it comes more than 540 degrees. So a few information which are important to understand the temporal bone anatomy. This is not complete, of course. This is a huge topic. We could speak about the different details, weeks or months, but maybe you could have a few other view or other information, and I hope you can use this the information, this views, pictures in your everyday activity. Thank you very much, and I am open if you have any question to give answers. Thank you very much.
So the chat is now open for questions. So please write your question into the chat. I will have a look at it and then ask Dr. Tóth about it. In the meantime, I have to say I enjoyed all the presentation. The preparations are wonderful. And I would like to mention also your last slide. Maybe we can have a look at the last slide. I'm sorry, but I have to ask that question. You see a wonderful preparation there. And yeah, the whole electrode entering the cochlear. So it seems that the electrode, I hope you can see it right now, it seems that the electrode is tailored for that individual cochlea, and you're using the Flex 28. My question is, how important is it to have a whole portfolio of electrodes in order to fit the exact size, in your opinion?
I think the most important thing, again, the skeletonization. Skeletonization of the round window niche. Unfortunately, in this picture, I can't demonstrate the typical form of the round window, but a round window niche has a posterior, superior, and anterior border. This is the postis anterior, the tegument of the round window, and the postis posterior. This is a cartilaginous bone, so enchondral bone. You should remove that as far as that you can see the whole secondary tympanic membrane. And after that, depending on the point what you can see, the pre-operative CT scan, you should open the cochlea, the scala tympani, in the antero-inferior area, sometimes outside the round window niche. And you can have a direct view, an axis just in the middle of the basal turn. If you are near the carotid canal, you can't direct the pathway of the electrode, but you can make an optimal view in the first 4 to 6 millimeters. This is absolutely the prerequisite for a good insertion of the electrode from morphological view.
Mm-hmm. And how important it is, again, to have different lengths of the electrode in your wheel?
It depends from the on the cochlea. You can regulate just in this first 4, 6 electrodes. The other parts of the electrode will follow just the anatomy of the cochlea. But it is so important to put in the real position. This is the apex of the cochlea. If you don't open this area, the electrode will comes first laterally and after that medially. And this is not optimal. If you make impedance measuring, you can see such a way, because here in this area you are far from the ganglion area. Here is very close, and here in the apical area, again relatively far. If you stay in this area, your impedance measuring has not such a curve, but this is a relatively horizontal level. It means the same impedance in the whole pathway of the electrode. So we can say it, if you make a proper opening here, you can see intraoperative measuring that. So morphology and physiology are close together.
Very good. So to summarize that, in order to have a smooth insertion with a structure preservation, and maybe also if the patient has hearing preservation, to know the anatomy very well and the histology is very important, just to choose the right spot, to drill out the right spot, understand if there is a mucosal fault or the real tympanic, the round window membrane, and then insert the electrode with the proper angle, right? Very good. Let's see whether there are some questions in the chat. If not, then that's the opportunity for me to ask another question, right?
Let's do it.
Yeah. So you have been showing in your presentation very interesting aspects. When it comes, for example, to pathological ear, right? There are some spots in the middle ear which are quite difficult to reach, I understand, but where there might be a hurt for the pathology, right? So this anatomy is very important for the surgeons to understand in order to avoid any other difficulties and complications afterwards. You showed one. I think it's in the Prusak space, if I was not,
yes.
if I'm not wrong. Is it really right? Oh, This makes me happy. But there are other ones, right? Can you give us some further information for surgeons? They operate in a pathological ear. Which are the spots you would look at a little bit more in depth?
It depends on the case, of course.
Mm-hmm. Yeah.
But it shows what you mentioned, that the CT scan, pre-operative CT scan is absolutely important thing. This is a prerequisite for good surgery, because before surgery, with the help of the CT scan, you can see where can you find these spots. Mm-hmm. And so in case of a simple tympanic membrane reconstruction, so except this this operation, I need a CT scan before all the operation, temporal bone operation. If you would like to see what kind of structures are important during surgery in order to remove all the pathology and preserve the important structures, I would say in an ear is almost in all the cases is a stable structure. So if you have the inner ear, you are in a safe position. Facial canal is also a very important thing. The facial canal, tympanic portion, is positioned directly on the lateral surface of the otic capsule. In case of bony covering of the tympanic portion of the facial nerve, this is not a developmental problem. So this is not a malformation. You can see that in the CT scan. If you have a facial canal, this is not a malformation. This is not valid for the mastoid portion. So mastoid portion to skeletonize in different pathological cases not so easy. Even in case of a granulation tissue, it can be very bloody. You have to open the mastoid very large, and you have to make a proper skeletonization, and step by step with good irrigation, you have to identify in a large surface the structures. And after that, you can open the areas of the tympanic cavity in order to have the pathology. The posterior opening of the tympanic can be very dangerous if you don't make a large surface. This is always a discussion, minimal invasive opening or not. I would say we have to try to make a minimal invasive opening. If it's not safe, in this case, we have to choose a large approach. And this is valid for the epitympanum as well. In many cases, the problem is the focus of the pathology is in the epitympanum. So a posterior or lateral anticotomy is absolutely important. In case of a simple tympanic membrane perforation as well, we could see the different atelectasia. What happens? There is a block at the border between the epi and mesotympanum. In order, if we just close the tympanic membrane, we did nothing in order to prevent the further perforation. Maybe it takes half a year or 2 years, but the same problem we will have, and we can make a next repair of the tympanic membrane. And this is not a good solution, just put a strong material cartilage. So opening from lateral or posterior opening of the epitympanum is absolutely important. So facial nerve is absolutely important. We have to know in all the cases the real position of the facial nerve. Sometimes in special pathology is this without bony covering. And the carotid artery, it can be positioned very posterior. Sometimes the carotid artery can reach the round window niche. Yeah. In this case, we can't see bony covering. Mm-hmm. So this is also a special thing. I could explain such a situation in the following 45 minutes, but answer for your question, I would say shortly that.
No, very good. There is a very interesting question in the chat. and which is what are the research gaps in cholesteatoma pathophysiology and surgery. This is the first one. And then we have another one. What are the knowledge gaps in temporal bone anatomy and physiology with respect to CI? So the first one is about cholesteatoma pathology.
Cholesteatoma develops mostly as a result of retraction. And other development, the metaplasia without any perforation, the epithelium of the on the medial side of the tympanic membrane develops. I would say we should have always a large enough exposure of the surgical field, and step by step under visual control remove the cholesteatoma with one approach or bitemporal approach, but always under vision. In these cases, the endoscope can be a huge help. In many cholesteatoma surgery, I would say the endoscope itself, only just endoscope is not enough. We can see recitative ray, but in small cholesteatoma, yes. Used to be the technique was just follow the epithelium. We live in the CT scan and MRI time, so that is why we can see very exactly in many cases how large the cholesteatoma is, and we can choose the proper approach. I would say cholesteatoma can be a very easy thing and sometimes a huge operation, even if the cholesteatoma is small, but is positioned in the wrong, in a very difficult
area to reach.
area. And so, other question, CI and?
Yeah, just for the cholesteatoma, I would like to ask an additional question. So if I understand that correctly, you would suggest a microscope as well as the endoscope with the preservation of the posterior wall in order to make sure that you'll see the cholesteatoma very well and you can eliminate that. If that's not sufficient, then the removal of the posterior wall would be necessary. Is that right?
Generally, yes, but it depends on the patient. I think all the cases need a good plan. So operatively to see the how large the cholesteatoma, which area are reached or can be reached. Sometimes this is a difficult thing. Can I use a closed cavity or should I use an open cavity? If it is a question, this is my philosophy. I plan an open cavity, but I'm starting with a closed cavity. I am prepared that if it's necessary, I can change the whole situation, surgical field, to a canal wall down technique.
Very good. So that means that we integrate this knowledge with MRI, with CT, maybe with contrast, but nevertheless, the final decision will be intraoperatively.
Of course, yes.
Yeah. So the other question was knowledge gaps in temporal bone anatomy and physiology with respect of the cochlear implants.
I think cochlear implantation is the easiest task for the surgeon, because the audiologist will show, okay, this patient need a cochlear implantation, and audiologist and the technical colleagues will make the postoperative changes. The surgeon has about 1.5 hour activity. And if we open in the real position the cochlea and enter the electrode, it should be result a good function. What we can decide the position of the electrode within the cochlea, and that is why it is absolutely important in which area we opened the cochlea. So the round window niche. The surgeon itself should see the CT scan and MRI before the operation, not to read the text from the radiologist, because in a few cases we can see intracochlear acoustic neuroma. We can find that in T2 sequences, the MRI, there is no fluid within the cochlea. The radiologist, we are lucky if we have such a radiologist, but in many hospitals, this is not the reality, and we should see whether there is a malformation in the scala. Vestibule is larger than the scala tympani. In this case, we have to open the cochlea just below the stapes. So in most of the cases, we open in the area of the round window, we put the electrode into the cochlea, and we hope that the second and third turn is also in a good function. Good reaction of the electrode stimulation. I would mention that about 5–6% of the cases, through posterior tympanotomy, the round window niche is not visible. In this case, we have to make a cochleostoma. It is not so well known, but I made a study. 100 macerated temporal bone I dissected just with this purpose, and I could see in my OP activity, I could say that's true. So we have to learn in the dissection room that as well. How can we make a cochleostoma or opening of the cochlea in other places than round window niche?
Very good. So that's for sure a key message we can take home from your explanations. I think time is running, and I really would like to ask you another question about embryology, how important it is in the normal anatomy or in the malformed anatomy, but I don't think there's any time for that anymore. I'm looking at my colleagues here. Is there time for one only? Yes, there is time for this question. How important is it, in your opinion, to have knowledge about embryology in order to perform normal surgery in a normal anatomy? And how important does it get in case of malformation of the Treacher Collins or any other malformation?
I would say a good ear surgeon, I would say a good temporal bone surgeon should be an excellent radiologist as well. We should learn how can we read the different signs from the CT scan and MRI. CT scan is more important than the MRI for the surgeon because of the anatomy, to plan the surgical approach, the finding, how looks the pathology, what's that, both the CT scan and MRI, both are very important, but we have to learn that.
Mm-hmm.
And
my question was more about embryology, not radiology.
Embryology. Yeah. Embryology is a difficult thing and borrowing thing for many people. I learned that. I took a good examination, and I would like to forget that. But in case of a malformation within the temporal bone, I learned a lot of books, but this situation I've never seen. It is possible to understand what is the situation in the actual case, what I am here in the OP theater, if I learn the embryology, because I know how the facial nerve develops, in which cases I can't see bone around the nerve. If there is no bone around the nerve, where can I find the nerve? How can I expect which signs goes to see the duplicate facial nerve? If I can't see the round window niche, how can I open safe the inner ear? All the information can you find in the embryology, and embryology is always histology. To learn the embryology, you have to see a lot of histology. Before birth, the different ages, if it takes time, it's really time confusing thing, but it is worth to learn that. After that, the surgery is really safe for surgeon and for patient.
Excellent. Thank you so much for this information. Maybe I can share the last slide with you. I really would enjoy discussing this topic much further. We should plan another surgery online, hopefully. That would be great to continue our nice conversation. But before this one ends, I would like to show you the book again. All the pictures we have seen during your presentation are actually also contained in the book. Anatomical guidelines for temporal bone surgery. Please just open the address, the web address there, or use the QR code, and you will be directed to that. It's really a recommended read to know more about embryology, know more about radiology, anatomy, histology. It's very going into depth with this topic, so it's highly recommended. And that's now, unfortunately, the last slide. There will be no October session due to the fact that there is a public holiday in Austria. But on the 23rd of November, we would like to welcome you again to Surgery Online, and we will announce the topic about the upcoming one in November very shortly via email, or you find it also on the website. So a big thanks goes to Dr. Dott. It was really a pleasure to have you and discuss this interesting topic. And like I said before, I hope there will be a sequel of it, just to use a term which is often used by pathologists. Thank you very much.
Thank you very much for the invitation. I enjoyed it.